Welcome to the unit on crisis and trauma counseling and interventions. In this unit, we will discuss assessment of client risk and development of a safety plan, effective rehabilitation counseling services for individuals with polytrauma injuries, impact of crises, disasters, and other trauma-causing events on people with disabilities, principles of crisis intervention for people with disabilities during crises, disasters, and other trauma-causing events, the emergency management system within rehabilitation agencies and in the community. Crises occurs when an individual experiences an event which overwhelms their psychological adaptation and coping skills. Crisis intervention seeks to restore this functioning through the development of resilience, empowerment, and recovery. Crisis counseling does not involve the provision of therapy. It is of a short duration. Crisis counseling involves active listening, offering reassurance, providing practical assistance, providing psychoeducation, providing emotional support, providing behavioral techniques for coping with trauma and stress, providing information and referral to necessary professional resources, including psychotherapy. Polytrauma is defined as more than one severe injury arising from a single traumatic event. This definition sometimes refers to an injury to two or more body systems simultaneously arising from a single traumatic event, as opposed to a multi-traumatic event arising from more than one trauma to a single body system simultaneously. Traumatic brain injuries, or TBI, often co-occur in polytraumatic experiences. Polytrauma treatment results in greater care intensity and a greater caregiver burden. Considerations for treating polytrauma involve three processes: initial presentation, management of symptoms, follow-up of persistent symptoms, and necessarily include caregiving. Caregiver stressors includes consumer functional limitations and care intensity. Moderators includes consumer resources, social, family, financial, interpersonal. Outcomes includes caregiver burden and caregiver mental health issues. The duration of caregiving and the caregiving living situation also have an impact on outcomes. Vocational rehabilitation considerations include familial support regarding the management of social supports, familial facilitation of the development of consumer coping strategies. Family members may consider joining a caregiver support group. Workplace modifications, duration of work, graduated immersion, change of jobs or modified tasks, job coaching, or increased supervision. Referral to a placement provider for structured vocational supports. The impact of trauma on a person's mental health is variable. It depends on factors such as whether there is an effective support system in place, the resiliency of the person, and personal history regarding traumatic experiences. Research indicates that traumatic experiences can influence mental health and physical health. Substance use, such as smoking cigarettes, drinking alcohol, taking drugs, and risk-taking behavior, such as sexual promiscuity and self-injury, can be problematic. Trauma can result in impairments in major life domains such as social engagement, work, and school. According to the Substance Abuse and Mental Health Services Administration, or SAMHSA, trauma to an individual results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental health, physical, social, emotional, or spiritual well-being. The SAMHSA 3 E's reflect this: event, experience of the events, and the effects of the events. The SAMHSA 4 R's reflect the key assumptions in a trauma-informed approach: realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. The Substance Abuse Mental Health Services Administration also offers a 6-principle model for a trauma-informed approach. These principles were designed to help any system providing services and supports to a traumatized individual to avoid being trauma-inducing themselves and avoid re-traumatization of clients. Safety. An emphasis is placed on clients feeling physically and psychologically safe. Interpersonal interactions promote client safety. Trustworthiness and transparency. Organizational processes and decision-making is transparent, promoting client and family trust. Peer support. The idea of mutual self-help with a focus on other trauma survivors or family members for children, which promotes safety, trust, collaboration, and utilizing shared experiences toward recovery. Collaboration and mutuality. Reducing power differentials between clients and organizational staff toward the recognition that relationships are therapeutic and that everyone has a role to play in a trauma-informed approach. Empowerment, voice, and choice. Building upon a client's strengths and lived experiences toward recognizing these as unifying. Person-centered services and informed choice empower staff and clients alike. Cultural, historical, and gender issues. Actively avoid stereotypes and bias toward being sensitive to individuals' racial, ethnic, and cultural needs, including historical trauma. See the additional resources for this module for more information regarding the trauma-informed approach. In the United States, the incidence of suicide tends to double that of homicides, and suicide ranks in the top 10 causes of death for people ages 15 to 24. This rate continues to rise. It is important to note that of those who committed suicide, 33% had utilized the mental health system in some capacity, with 20% having done so within the last month of their lives. In fact, the American Foundation for Suicide Prevention finds that although there is no single indicator for suicide risk, mental health issues are most often associated with suicide. The National Suicide Prevention Lifeline, NSPL Suicide Risk Assessment Standards identify 4 categories of risk for self or others. Suicidal desire, ideation, psychological pain, hopelessness, helplessness, perception of being a burden to others, feeling trapped and feeling alone. Suicidal capability, history of violence and suicide attempts, exposure to a suicide, access to a means for suicide, intoxication and substance abuse, acute mental health condition, extreme agitation and/or rage. Suicidal intent. Attempt is in progress. Plan with a method in place for self or other. Preparatory behavior, expressed intention, and buffers and connectedness. Need to determine immediate and social supports. Engage in planning for the future. Identify and engage helpers. Work with ambivalence for living and dying. Engage in widen discrepancy toward living. Reinforce core values and beliefs and sense of purpose. The principles related to assessing suicide and homicide risk are essentially the same. At some point, vocational rehabilitation counselors will come in contact with at-risk consumers. It behooves counselors then to better understand consumer risk and safety. The University of California, Berkeley School of Social Welfare offers a continuum of actions related to serious, foreseeable, and imminent harm to a consumer or other identifiable persons. They suggest there is an inverse relationship between consumer confidentiality, self-determination, and external intervention with threat severity and consumer vulnerability. As a counselor determines that a consumer threat or vulnerability rises to a level representing an unacceptable risk to the consumer or some other identified person's well-being, and safety confidentiality may be breached as a means to provide necessary interventions. When an at-risk consumer presents as a potential threat to their own or others' safety, there tend to be common factors associated with consumer distress. History of suicidal gestures. History of mental illness, especially mood disorders. Alcohol and other drug use. Familial history of suicidal gestures. Feelings of hopelessness. Impulsive or aggressive behavior. Barriers to mental health services or not availing themselves to services. sense of loss in their life, ready access to hazards and environments, stigma and negative perceptions related to mental health issues, social experience of suicide, either personally, through media, or culturally, spiritual or religious beliefs or influences, personal belief systems, illness or disabling condition, social isolation. As a counselor, bringing up the topic of suicide will not lead to a suicide attempt. In most cases, consumers are accepting of a counselor's concern for their welfare and relieved to have the topic addressed. See the additional resources for this module for more information regarding suicide risk. The Tarasoff ruling in 1974 found that professionals working in the social services have a duty to warn and to protect potential victims from harm, as well as to protect consumers from potential self-harm. This responsibility is an ethical obligation in the helping professions. Applebaum in 1985 suggests 3 phases to determining whether a duty to warn is present. Obtain all relevant information and make a determination regarding the presence of consumer danger. Determine a course of action. Implement the determined course of action. Developing a safety plan with at-risk consumers is an important part of maintaining safety and managing risk. A safety plan may include the following: identifying the warning signs of a developing crisis, developing coping strategies and adaptive skills for self-regulation, identifying support systems and supportive others to utilize in times of need, identifying adaptive distractions to draw attention away from harmful thoughts, involving family who can provide support in times of crisis, identifying professional service providers to utilize in times of crisis, organizing and/or prioritizing contacts to facilitate access to needed supports and services in times of crisis, ensuring the environment is safe and free from potential or foreseeable hazards during a crisis. Emergency preparedness plans should be developed in collaboration with individuals with disabilities and the professionals who work with them to ensure individuals' needs and plan effectiveness are addressed. People with disabilities have varied needs which must be considered, such as accessibility of transportation and shelters, hearing warnings, mobility, orientation when common environments are no longer accessible. ADA.gov finds that the most common issues impacting people with disabilities in emergency preparedness include notification, evacuation, emergency transportation, sheltering, access to medications, refrigeration and backup power, access to their mobility devices or service animals while in transit or at shelters, access to information. The Federal Emergency Management Agency and the American Red Cross suggests a 4-step process for emergency preparedness for individuals with disabilities. Number 1, get informed. Check into community hazards. Check into community disaster plans. Check into community warning systems. Check into assistance programs. 2, make an emergency plan. Communicate with family, personal care providers, landlords, and building managers. Communicate with a contact or contacts who do not live in the same town, for calls may be easier long distance than locally in a disaster. Plan escape routes. Plan for pets, therapy and/or service animals. Plan for potential hazards or barriers. 3, assemble a disaster kit. Plan for a 3-day supply of essentials such as medication, food, clothing, batteries, first aid, sanitation, pet supplies, and so on. Be aware of weather and seasons, and dress appropriately. Consider vehicular supplies such as jumper cables, flares, fluids, etc. And 4, maintain both the emergency plan and the disaster kit. Quiz family and friends relying on the plan. Drill and practice the plan. Restock. Check expiration dates and restock water every 6 months, and so on. Test. Check alarms, fire extinguishers, batteries, etc. The Wisconsin Council on Physical Disabilities Emergency Preparedness Toolkit for Persons with Disabilities developed a comprehensive guide regarding important items to consider in emergency or disaster events specific to people with disabilities. The toolkit facilitates consumer organization around 7 general categories: All-purpose items: fire blanket, 12-volt heater, fan, hat and gloves or mittens, rain gear, thermal blankets, toolkits, etc. Communication devices such as laptops, mobile devices, software, communication boards, AAC devices, visual communication tools. Signaling devices such as bed shakers, flashers, wandering alerts, etc. Mobility devices and aids such as canes, crutches, walkers, manual or power wheelchairs, wheelchair repair kits or battery chargers, wheelchair cushions or covers, lap boards, spare parts, tires, inner tubes, patient lifts or slings, transfer boards, etc. Prosthetic or orthotic devices such as artificial limbs including necessary battery power, braces, specialty footwear and inserts, etc. Assistive technology devices, specialty eating and or drinking devices, lapboards and trays, food package opening devices, power inverter DC to AC, power supply options such as solar, propane, or wind. Medical alerting devices such as bracelets, necklaces, or wallet cards. Dietary needs information, a 3 to 7 day supply of prescriptions and medical supplies, EpiPens, insulin, protective headgear, respiratory aids such as a CPAP, nebulizer, inhalers, oxygen concentrators or oxygen tanks, and so on, wound care supplies, bowel or bladder supplies, and so on. Old equipment, items, and tools which are still in proper working order can be reserved and stored in an emergency go bag to facilitate grab-and-go readiness at a moment's notice.